Nicolas, where's the rest of the class?
I'm going to text them now.
Okay, great.
Hi, doctor.
Hi, doctor.
Joya, can you come in today?
So yes, 2 more syrups.
Okay, let's hope it will be the last time. Great. So can we start?
Yes.
Yes. So today we will be talking about the use of pharmacoepidemiology to study beneficial drug effects. So we always hear the word safe and effective as being the words that we need in order for a drug to be on the market. So as I previously described in chapters before, which I'm guessing you remember nothing of.
We read it.
Yes, we read it last time.
Oh, great.
Together.
Wow,
Twice.
really
Yes,
great.
twice.
Okay. So as I was saying, assuming you remember that preclinical studies and pre-marketing studies do not give you sufficient amount of information in order to give you everything you need about the toxicity and efficacy of a drug as seen clinically. Now, today I will begin by defining the various types of beneficial drug effects, and then you will have to continue because I expect that you studied everything.
Yes.
Okay. So we're going to start with an unanticipated beneficial drug effect. An unanticipated beneficial drug effect is a desired effect that was unanticipated, which means it was not expected at the time the drug was marketed. Even though this may be used clinically as something that's positive, we would still consider it as a side effect. Now, the most amazing example about this is aspirin. We all know aspirin has been here for a long period of time, and it's an NSAID. This unanticipated beneficial day effect we found post-marketing was actually that it can be used to prevent MI. Now, the good thing about this is that it's very helpful nowadays, but there is a challenge where we're trying to discover if other NSAIDs have this extra effect that aspirin showed. As for anticipated beneficial drug effects, are the desired effect that you were anticipating when you marketed the drug, and it's the purpose why the drug is on the market. Now, considering we're talking about this, we would here discuss efficacy. Yara, can you please describe to me what efficacy is?
Yes, it's whenever the drug shows its intended effect, but in a controlled and ideal setting.
Like in what type of studies?
RCTs.
Excellent. And Nicolas, what's effectiveness?
So it's the ability of the drug to do its intended effect, but in the real world. So in the real
So we can all agree that you have to be, every single drug needs to be efficacious, and you need to say that it's efficacious in order to establish the effectiveness, and no drug can be effective if it's not efficacious. Now there's a new term that you don't always hear, and it's efficiency, which is basically the ability of the drug to do its desired effect at an appropriate cost. Mrs. Samaha, is everything okay?
Yes.
Yes.
No, it was.
Yes, I saw you looking at your phone. If you're not very interested, you can leave the classroom. Great. Okay, so we continue on unanticipated harmful effect. So it's a harmful effect or an undesired effect that we couldn't have expected at the time of marketing based on the preclinical studies, based on the pharmacology of the drug. Now, Joya, can you please give me an example of an unanticipated harmful effect?
Yes.
Yes.
Yes. The one about chloramphenicol.
Yes,
and
what did it show?
aplastic anemia.
Yes, but I would rather you focus on more important and more newer drugs that you see on the market, such as statins. It's very common, you see it in the pharmacies every day, and this harmful effect that we saw was basically the muscle pain. Great. Well, we should also note that this unanticipated harmful effect is a type B category, which, as you remember, it represents bizarre from the 1981 Thompson and Rowland's classification.
Doctor?
Yes.
Is this included in the exam?
Yes, it is, sadly. You have everything I said for the exam. Now, as for anticipated harmful effects, are usually the harmful effects that we do expect at the time of marketing. They are inevitable, they are because of the pharmacology of the drug. Preclinically, we know of them, and they're usually classified as either being A, augmented, or B, bizarre. Now, the interesting thing about the anticipated harmful effect is the challenge we have in order to find the incidence and how much they're happening after the drug was marketed. Now, technically my job is done here. I expect that all of you are ready to present your parts. I'm going to go at random, so we're going to start with Yara. I would like you to start explaining the clinical challenges and problems that need to be addressed by pharmacoepidemiological research, please.
Yes, sure.
In order to make optimal clinical decision, a physician has to be able to find out if the drug that they're going to prescribe to their patient is efficacious and the degree to which it is effective. So usually to get such information, one would get them from the pre-marketing random clinical trials. These trials usually focus on showing if the drug is actually effective and has the intent that it actually does. So how are they usually done? So usually the pre-marketing types of studies, they recruit patients and then they're gonna randomly allocate them into the treatment group or into the placebo group. The treatment group are obviously the ones that will receive the drug versus the placebo. They will then monitor the patients up until the outcome occurs, and this is how they can show that the drug is effective or not. One has to remember, however, that these types of trials usually happen in an atypical and an ideal setting, meaning that they can actually control variables that could affect or bias the research in any way, such as the patient's clinical baseline characteristic like age and gender, the patient's other comorbidities, the patient's other drugs that they're possibly taking, as well as the patient's compliance and adherence. So by having these restrictions, these types of trials tend to maximize the efficacy of the drug. However, we do require additional information about the efficacy of the drug at the time of marketing or at post-marketing, and these are the information that we tend to lack usually. Also, one has to be able to know if the drug will still be able to have that same effect once used in clinical practice. So when other factors that we encounter, such as differences when it comes to the dosing in terms of frequency of dosage, when it comes to the different nationalities of our patients or different drugs that the patient are taking that could potentially affect the drug, are not usually taken into consideration in pre-marketing types of studies. So one study that was conducted in 1978 took the 100 most commonly prescribed drugs, and their aim was to show the lack of information about the efficacy of the drugs at the time of marketing. So one example is 8 of the drugs that were most commonly prescribed were actually prescribed for a long-term effect that was not proved in the clinical trials. In fact, the clinical trials, the pre-marketing, were only able to show the intermediate effect of the drugs and not the long-term effect. As an example are the antihypertensive drugs. We tend to prescribe them to the patient to prevent long-term cardiovascular effects when in fact they're only studied for their antihypertensive effects. So this study was able to show the gaps that we have about the efficacy of the drugs at the time of marketing and during post-marketing. However, this is not surprising, as the data that is needed in order to approve of a drug is different than the data needed to show the therapeutic efficacy of the drug. However, it's important to note that these gaps are present and that we should act on them.
Can you tell me about methodological problems that we need to address in pharmacoepidemiological research?
Okay, so confounding by the indication for therapy is a problem in studies of intended drug effects. So a confounding variable is a variable other than the risk factor and the outcome variable under study that is independently related to both of them. So it could create an apparent association or it could mask a real one. In the case of studies of intended drug effects, we know that the risk variable would be the drug and the outcome variable would be the clinical condition that the drug is supposed to change, for example, to cure an infection.
Can you give me a specific example?
Yeah. Okay, so let's say we want to evaluate the efficacy of prescribing a beta blocker after an MI in order to prevent another incidence of MI. So we can conduct a cohort study comparing patients who were treated with a beta blocker post-myocardial infarction to patients who were not. And then we can measure the incidence of subsequent myocardial infarction in both groups. However, we know that patients with angina, arrhythmia, and hypertension, they're all indications for beta blocker. So they're going to be more prone to develop subsequent myocardial infarction. So we might observe in the study an increase in the risk of MI rather than the expected decrease. So even if the use of the drug is beneficial, it might appear to be harmful. So if a study is focusing on unexpected side effects, whether harmful or beneficial, the indication for treatment is not usually related to the outcome variable. So in this case, confounding by the indication would not really be a problem. However, in some cases, we might encounter the problem of confounding by indication. In studies of anticipated beneficial effects, the indication is more closely related to the indication, so to the outcome variable, sorry. So if we use non-experimental approaches, like in this case, the indication would be a confounder. So that's why we prefer randomized controlled trials. But with randomized controlled trials, we face the same issues that we encounter with experimental approaches, like, for example, let's say ethical restrictions or artificial medical settings.
I would like to show you a video that was prepared by my colleague in the US about the currently available solutions for the problems that are faced by pharmacoepidemiological research.
We do not always need randomized clinical trials to study beneficial drug effects. So what are the available solutions? Research questions are classified according to their problems of confounding by the indication for therapy. First, there are situations that do not require any comparative research for their answer. Let's take the example of a patient that is in coma from an overdose of methadone. If we inject him with naloxone, this results with his prompt awakening. However, 30 minutes later, as the effect of the narcotic antagonist wear off, the patient will return to coma. Another injection of naloxone will result in awakening once more, and then later the coma will return again. This sequence of events show that the drug effect is obvious, and there is no need to do more studies to prove it. The same concept applies to a case series of patients treated with penicillin for their pneumococcal pneumonia. The second problem of confounding by indication is when there is no indication. Here the benefit of the drug can be shown using non-experimental studies because there is no confounding by the indication. The situation can be better understood by an example of vaccination as a primary prevention. Third problem that we have is when the confounding exists but can be controllable. In this situation, the indication may be dichotomous or sufficiently characterizable. When the indication is dichotomous, we have 4 cases. For example, to prevent erythroblastosis fetalis, we give an anti-immunoglobulin to rhesus-negative mother who delivers newborn that are rhesus-positive. In this situation, the indication is dichotomous, but gradation in the indication do not exist. Second, when we give penicillin to patients for endocarditis prophylaxis who are undergoing tooth extraction, here the gradation in the indication are not related to the choice of treatment. Third, we have a situation where the gradation in the indication are unrelated to the expected outcome, such as when giving penicillin to prevent tertiary syphilis for patients with an asymptomatic positive serology test for syphilis. The last example of this section is when the availability of drugs is limited or there are different opinions among prescribers for using or not the drug. Then the gradation in the indication will not be related to the choice of therapy. If an indication is graded but can be sufficiently and precisely measured, it can be controlled by mathematical modeling, such as using multiple regression. Then confounding by the indication can be controlled and ruled out as the cause for an observed beneficial effect of the drug. When questions of intended drug effects do not fall into any of the preceding categories, confounding by the indication cannot be controlled. Non-experimental study designs cannot be used, or they can only be used to demonstrate the quality of some beneficial drug effect.
Please give us an example of a non-experimental study design.
Yes. As we know, non-experimental study design have been used to evaluate the efficacy of vaccines. Case-control trials and cohort study trial have been used. For example, case-control to evaluate the efficacy of measles vaccine and cohort study to evaluate the efficacy of hemophilus vaccine. Ideally, as we know, randomized controlled trial is the best and ideal design to study the effect of the vaccine. But since these diseases are infrequent, especially in a population that have already been vaccinated partly, non-experimental design have been used instead. We can say that non-experimental design in this case are valid. Why? Because patients receiving the vaccine are not likely to be different from the patient who did not receive the vaccine, because the physician's perception about the patient risk must be the same among all the population. We can conclude that non-experimental design are being a standard and accepted approach to evaluate efficacy of the vaccine now.
Thank you. We're filming.
ده انت ما tell me you're filming. Great.
شو Nicolas, where is the rest of the class? Please give me an example of a non-experimental study design.
Yes, as you know previously, Miriam